webinar of the 21st chapter of the Surgical Forum of the International College of Surgeons Indonesia section. My name is Peter John Manopo, General Surgeon. I am the coordinator of this Surgical Forum, and I will be your moderator for these sessions. On behalf of the International College of Surgeons Indonesia section, I would like to express my gratitude for all participants, particularly to our speakers, Professor Emilia, PhD. She is a OBGyn surgeon. And then Professor Helena Pereira de Melo. She is a bioethicist from School of Law, University of Lisbon. And Professor Puruhito, PhD. He is a Cardiothoracovascular surgeon. And also for the office bearers from the international headquarters, Professor Georgios Tsoulfas, the world president from Greece, and then Mr. Max Downham, the world executive officer from ICS Global from Chicago, USA, Professor Hendy Hendarto, the Vice Scientific President of the ICS Indonesia section, Professor Andi Asadul Islam, the Research Vice President of ICS Indonesia section, and also Dr. Franciscus Arifin, but at the moment he is attending the virtual meeting with the World Congress in the Bangkok, Thailand. So possibly he will be as a passive attendee. Now we come to the opening session. And for the first opportunity, I would like to invite Professor Sri Maliawan, the President-elect of the ICS Indonesia section. Professor Sri Maliawan, the floor is yours. Maybe later I will skip, and I would like to invite Professor Hendy Hendarto, the Vice President of ICS Indonesia section, to address the scientific notes. Professor Hendy Hendarto, the floor is yours.
Thank you, Dr. Peter. Good evening, good morning, good afternoon, everybody. Welcome and thank you for joining the International Fetal Surgical Forum, Chapter 21, the International College of Surgeons Indonesian section. I would like to express my deepest gratitude and appreciation to Professor Paul Tahlili, Mr. Mac Downham, and also the speaker, Professor Emilia, Professor Helena Pereira de Melo, Professor Puruhito, Professor Maliawan, and Dr. Peter, and also all the webinar participants. From the scientific note, I would like to inform you about the article of from the Amazon Web Service with the title, How Important is Ethics in the Doctor Profession? This article is the opinion of the community, not a doctor. They state that posturing about ethics is very important for a doctor, as they are a profession built on profiting from people's accidents and illnesses. No other person is charged with providing healthcare like a doctor. Doctors are dealing with life, death, and the well-being of fellow human beings. If the doctor do not serve a model of best practice, honesty, and integrity, get out and go into the other job or something that's heavy. Medical practice is an inherently moral profession in which notion of trust, care, and meaningful relationship from the foundation of being a good doctor. That's all I think about the ethic in the doctor profession in scientific note. I hope we'll stay healthy, stay safe, and finally, thank you all speaker for sharing your experience. Thank you very much for your attention.
Thank you very much, Professor Hendy Hendarto, for your scientific notes. And for the next opportunity, I would like to invite Professor Sri Maliawan. Are you on the line? Okay, I will skip. I would like to invite Professor Georgios Tsoulfas, the world president of the ICS Global. Professor Georgios Tsoulfas, the floor is yours. Okay, I will skip, and then for the next opportunity, I would like to invite Mr. Max Downham, the Executive Director of ICS Global from Chicago, USA. Mr. Max Downham, the floor is yours.
Thank you, Dr. Manopo. It's my honor and always a privilege to be invited by you and your leadership to be participative in these webinars. And good evening to you all. In reference to Professor Emilia, Professor Pereira, Puruhito, Professor Maliawan, Dr. Arifin, Professor Hendarto, and Professor Asadol. Thank you so much for this privilege. Normally, Dr. Manopo gives me an opportunity to bring you up to date on the happenings, if you will, in the International College of Surgeons. And as Dr. Manopo and I were just speaking, and perhaps some of you have heard this or heard my remarks a couple of minutes ago, this is a time of elections in the Worldwide International College of Surgeons. And so this year, normally, were it not for COVID, we would be in Bangkok, Thailand at this time, participating in the 42nd Biennial World Congress of the International College of Surgeons, understanding that the college was founded by Dr. Max Thorek about 86 years ago. If you think about it, there aren't that many institutions in the world who have existed for that long. So we're very proud of that legacy. The Board of Governors is the group that votes in the elections. And it is a worldwide event. It's a major event. This year was done virtually and by direct mail ballot. The election has been completed in terms of voting, and today, as I was saying to Dr. Manopo, we count the votes. I don't know who the winners are, and even if I did, I wouldn't divulge the names here until it's properly, the candidates are properly notified. But the International College of Surgeons is technically a legal federation. And that means that, for example, in Indonesia, the Indonesian section of the ICS is independently incorporated within the laws of Indonesia. And then a contractual relationship exists with the parent body. So the point of these remarks is that the Indonesian section, this section, has control of its activities and what it does. And it's for this reason, Dr. Manopo and the leadership of the Indonesian section, that I really commend you again and again. I've said this many times before, I say it again, cannot say it too often, in fact. I commend you for your initiatives with these webinars. You are only to be congratulated. And I hope, as does the parent body leadership of the International College of Surgeons, speaking on behalf of our world president, Professor Georgios Tsoulfas, based in Thessaloniki, Greece, that other sections will emulate, will do what you are doing with these webinars. So I thank you very much for the opportunity to speak, Dr. Manopo, and I look forward to hearing the speakers. Thank you.
Thank you very much, Mr. Max Downham, for your updates of the ICS. And now we come to the scientific session. And for the first speaker, I would like to invite Professor Emilia, OBGyn surgeon. She will talk on challenges in medical abortion. Professor Emilia, the floor is yours. Professor please unmute your microphone.
Thank you very much, Pak
Okay.
Peter. Good evening, good morning, and good afternoon, everyone. So let me share the PowerPoint. Yes, okay. Can you already see the slides?
Yes, perfect.
Thank you very much, Pak Peter, for inviting me in this distinguished forum and with a very interesting topics. And you asked me to share about the challenge in medical abortion. And for this presentation, I will start with some case illustrations and also how the problem in the world, the problem in Indonesia, and what is the challenge for us for the future. Well, I will start with a case illustration because I believe that not all of you are OBGyn, yeah. So how is the case in OBGyn for medical abortion? So for example, here, a female admitted to emergency department and complaining of severe abdominal pain. And then she reported a termination of a 10 weeks unplanned and undesired pregnancy and taking some drugs purchased online. Then she developed bleeding on the following day, and she had uterine evacuation at a clinic. Yeah. The next day, start bleeding very heavily, vaginally, and then so she went back to the clinic and given the misoprostol tablet twice daily for a week. But then she continued to bleed, and second uterine evacuation was performed on her at the same clinic. Then after returning home, the patient almost collapsed because of the severe pain. So her family brought her back to the hospital. At the hospital, she was conscious, anemic, and in obvious discomfort. And the abdominal examination shows generalized tenderness and guarding all over the abdomen. The bowel sounds were absent, and a clinical diagnosis of perforation, yeah, and leading to a bowel injury was made, and laparotomy was planned after resuscitations of patients. Then during laparotomy, the bowel was resected. So the issues here that we have the unintended pregnancy, which is still a problem. We also have a unsafe abortion, which leads to serious complications such as uterine perforation and also bowel injuries. And we also see here the problem of unsafe abortions, which is done by untrained personnel, so unskilled practitioner in very unhygienic conditions. The second case illustrations is a religious woman who is 27 weeks of gestation, referred by the regional hospital. And then unfortunately, from obstetric history, it turns out the patient doesn't check her pregnancy regularly because she lives in the rural area. So the presence of congenital abnormalities in the fetus was not detected early in the early weeks of pregnancy. The obstetric ultrasonography revealed multiple congenital anomalies in the form of acrania, cleft lip, and palate and gastroschisis. The estimated birth weight was 1,100 grams. So seeing the condition of the fetus that doesn't make possible to live, then the medical decision was termination of pregnancy. So here we also have some issues about this case, that termination of pregnancy in severe lethal congenital anomalies, of course, has ethical and moral challenge for both doctors and also the patients. And then the issues of legal and religious law perspective of pregnancy termination that is more than 28 weeks, or the fetus is more than 1,000 grams. And the problem of safest method for terminating the pregnancy, especially after the first trimester, and then the problem of education and information. The last illustrations is about high school girl, 16 years old, come with her parent to OBGyn clinic in the state hospital in order to terminate her unwanted pregnancy. A month ago, she was raped by a stranger while she was on the way home from school. So this case was handled by the police. Due to social and educational reason, her parent asked obstetrician to terminate the pregnancy. Currently, she was in 10 weeks of gestation. So this is also the issues, not only about the clinical, but also medical legal aspect of abortion for rape victim, and the problem of need of psychological support for this particular case. So those three cases show us that the delicate problems of medical abortions. When we look the abortion problem in the world globally, that each year more than 121 million unintended pregnancies occurred, in which I think about 40%, ended. 61% of these unintended pregnancies ended in abortion, which means 73 million abortion each year. So when we look at this graph, that the highest rates of abortion was found in countries with the most legal restriction. You see this. In high-income countries where abortion, high incomes is the green one, where abortion is broadly legal. So which means here broadly legal, that abortion is available on socioeconomic grounds. There were here 15, the rate is 15 abortion per 1,000 women of reproductive age, compared with in the middle income countries 44 per 1,000, and for the low income is 38. So in countries with that restrict abortions, the percentage of unintended pregnancies ending in abortion is also increased during the past 30 years, from 36% in 1919 to 50% in 2015. So it is a big increase of the number. But interestingly, to see here that the number of the unintended pregnancy rate was declined, recently, so from 79, per 1,000, so decline, although it is very slowly, up to 64. But the abortion rate still, I think, steadily, not increase, but I think this is steadily, So this is a problem of, what is the problem? Why the unintended pregnancy is going lower, but the abortion rate is still very high. Yeah. So the unintended lower means that the unmet pregnancy perhaps is also lower. Coming to the next slide. Yeah, we look at the worldwide number that around 30% of the abortions, which means 25 million, are unsafe. So from the previous slides, around 73 million abortion and 25 million are unsafe abortion. This is occurred every year. And when you look at in the global number, that the number with white illustration is abortion that is done safely. But the red and orange one is unsafe and mostly occurred in Asia, here around perhaps 40%. And Latin America and Africa is nearly 75%. So it is a big number. Yeah. So when we look at the abortion itself, so safe abortion in the world is around 55%, and the rest are unsafe. And the data also show that women in the poorest countries are most likely to have the unsafe abortion. So that is the reason why the maternal mortality in the poor country is still high. Yeah. And when we look at the medication abortion, which was introduced in early 2000. Medication abortion has transformed the practice of abortion care in the United States. Yeah, when look at here, so 6 months after the early introduction or the approval from FDA in 2000, so the medication abortion has, like here, 6%, yeah, 6% increased to 14%, 17%, and the last in 2014 is 31%. And all of these are abortion with medication abortion, which is usually done not in the hospital, so it is in the ambulatory. Yeah. So here, in 2016, the FDA also confirmed that the medication abortion is efficacious and safe, and become well established by both research and also experience. And the complications, especially the serious complications, is extremely rare. And how is the data in Indonesia? Unfortunately, we don't have like an exact data, a good data for abortion. We see from the data from the WHO that abortion rate is significantly higher in developing country compared to the developed region. And for Indonesian data from Guttmacher 2008 shows that around 2 million induced abortions is reported in year 2000, which is, this is the rates, 37 abortion per year per 1,000, yeah, of women with reproductive age. And here, I think this is high, yeah, when you look at the previous slide, yeah. And unsafe abortion is responsible for the higher and maternal death in Southeast Asian countries, yeah, especially with highly restrictive abortion law, including Indonesia, compared to those that legalize abortion. But this doesn't mean that we have to legalize abortion. And so this is also the reason why the estimates of abortion-associated mortality in Indonesia are unavailable. Yeah, the data is not available. Look at this estimate abortion rate in Java. Yeah, where here Jakarta is the highest. Yeah, so this is the estimate number, and the condition that is indication permit or not permitted for abortion. When look at this, that for condition permitted until 6 weeks for saving the woman's there is physical health or mental health, then this is not permitted. Yeah. And then the other thing is when there is a case of rape or incest or fetal impairment, then this is the permitted conditions without limit of the gestational age. And the two last is the economic or social reasons, and on request, this is the conditions that is not permitted. So this is in general what is the regulation is. So when we see the number, the profile in Indonesia, how is the abortion in Indonesia? We look here, who gets abortion? Most abortion clients are married and educated, and but they are a few of them are using contraceptives. Means that unmet need is still a problem in Indonesia. And the method of abortion in Indonesia mostly is vacuum aspiration or curettas, and also the oral medication and massage. Yeah. For the indication and contraindication, we divide into maternal and fetal indication. For maternal indications, we have like the mother will have disease like cardiovascular, genetic disease, or hematologic, neurologic, yeah, or renal disease, or any disorder that may like the pregnancy can make the high risk of mortality. And then the second is for the fetal indications is any condition that is make the fetus not able to live, like fetal malformation, chromosomal abnormalities, inherited metabolic defect, or fetal exposure, yeah, or radiation exposure. Of course, this should be examined first and diagnosed. Yeah, and for the contraindication is any condition that give negative reaction or make the worst conditions of the mother. So like if there is IUD in place, then it should be removed. And then allergy or other condition like chronic adrenal failure, ectopic pregnancy, or hemorrhagic disorder, etc. And so what is the challenge in medical abortion? Yes, actually the challenge, the most common barrier across different continents is lack of accurate knowledge. When you look at the illustration, so in the least restrictive country or in the most restrictive country, when you look at the green, yeah, color, this is where the safe abortion occur. Yeah. So here the problems is about the knowledge. Yeah. So whatever the legal setting, women do not receive adequate information. Yeah. How to get and where, yeah, to get the safe service for the woman. So that is one of the challenges. The other challenge in medical abortion is like the sources of the information are sometimes limited. We sometimes see that pharmacists, informal worker in the communities, or the internet, even the internet are often the only sources of information in setting where law is are restricted. So here, like most of them will ask the drug sellers, yeah, and we can see that most women who use misoprostol, where they buy online, purchase from a drug seller, receive incomplete informations about the medication abortion process. So that, of course, it will have potential problems, yeah, later on, yeah. Like for example, they don't being educated about how is the bleeding, the cramping, yeah, what is the complication that may happen. And so this is, I think, very familiar from I think friends from Indonesia, yeah, that the selling of the abortion drugs. The other challenge is the resistance or reluctance to provide care, yeah, among the current provider or the potential provider, yeah. So with many reasons actually, but like for example, the research in Michiokur reported that only less than 15% of medical students that they want or they would provide medical abortion service when they begin practicing medicine. So it means that the resistance is start since the beginning. That maybe it is related to the protecting professional terms, but it can be also a misconception or inaccurate knowledge about the safety of medical abortions. And so here, some of the reason for not offering abortion, like for lack of trained staff or lack of equipment or social or religious reason and not registered to provide abortion service, yeah. So in the Indonesia laws, yeah, some of the regulations also shows and regulate how the providers can take part in these cases. Like abortion can only performed by skilled healthcare professionals, which is certified by the Ministry of Health, and then only performed by certified healthcare service facilities. So with sufficient equipment and skilled healthcare professionals. And here also that some regulation that is related with rape victims and health-related condition. That so a feasible or ethical team needs to be established. So should be a team in that health facility. The team should consist of at least 2 health professionals, of which one should be a medical doctor who has the competencies and authority. Yeah, but the medical doctor should be so who is responsible to evacuate the product of consumption should be different from one of the ethical team. Yeah. So this is one of the regulation to protect the providers and also the patient itself. Yeah. So what is the opportunities in medical abortion? So despite the challenge, it is possible to explore innovative approaches to facilitating access to information, yeah, decentralizing medical abortion care. So make the access for the woman who need the service, yeah, they can access and bringing it closer to women. In setting where surgical abortion is difficult to occur, then medical abortion is an option. Yeah, and while it is also of benefit to women, medical abortion is also cost-effective for health system as well. So, what is the take-home message? So, we need here that consular information are the key and successful for early medical abortion. And we see that the research also already very advanced, and we need the dissemination of the study result that should be followed by the specific strategy so it can be implemented and accessed by the people. And number three, when faced with an unintended pregnancy, we always think that women will continue to seek ways to end the pregnancy, how it is safe or unsafe. So we need to think about it. And the evidence of the simplicity, safety of the medical abortion is, I think this is an option to expand the access to both safe abortion care and care for post-abortion complication. So we can help more women in the field who have the problem. I think this is the end of my presentation. Thank you very much for your attention.
Thank you very much, Professor Emilia, for your good presentation and informative presentation. We will get discussion after all sessions have been presented. For the next opportunity, I would like to invite Professor Helena Pereira de Melo. She is an bioethicist from the School of Law, Universities of Lisbon, Portugal. She will talk on ethicolegal dilemmas in medical abortion. Professor Helena Pereira de Melo, the floor is yours.
Thank you, Professor Peter Anopo. I would like in first place to salute you and to say that I'm very honored for the invitation to be here today. I would also like to say hello to my colleagues that are in the same table and to everyone that is today present in this conference. If you kindly allow me, I will begin my PowerPoint presentation. I'm going to try to, I don't know if you are seeing it, no?
Not yet.
Yes, here it is. Let me see if it is happening. Yes?
Yes.
Yes, it has appeared.
Please put it in a full screen size.
Let me see if I'm able to do it. Yes, I think I have. It is in full screen size.
Yes.
Thank you very much for the help.
Yeah,
I'm going to speak about ethical dilemmas in medical abortion, and the first article that I bring you is something that very much shocked me when it was published, and it still has not been repeated as far as I know. I bring you an article of the Journal of Medical Ethics that was published almost 10 years ago, in which the authors ask if we should accept after birth abortion. So the main argument that they bring to us is if the fetus and the baby that has been recently born have the same moral status, if we accept abortion in certain circumstances and in certain conditions, and we think that it is legally and ethically acceptable, why should we not accept it when the baby, the infant, presents exactly the same diseases, the same disability, the same conditions? Why should we not accept the same logic that we accept abortion after birth? It makes sense. And they say, they raise the argument that if in many countries, namely in Europe, we accept abortion when we have Down syndrome, and children with Down syndrome may have a perfectly acceptable life, then why should we not accept infanticide when the child who suffers from Down syndrome is already born? And so I only brought this article to you because I think that it is clear that it raises the most important issues that we have here. And the most important issues that we have here is what is a human fetus? And when you look at this picture, we can raise the question, what is a fetus from a biological point of view? And many of us will say that there is a continuity and that the status that we give to the fetus in the first image should be the status that we should give from an ethical and legal point of view to the fetus in the last picture that we have of it. But other of us will look at it and say that we have certain moments, namely when we begin to have a central nervous system, or when we begin to have a certain type of biological development, that would determine that the ethical and legal status would be different after that moment, after that frontier. And it's not possible to have only one answer. And people will have different ways of approaching this problem according to their religious and cultural preconceptions. And then we can move to the next question. What is the bioethical status of the human fetus? And again, we have more than 20 answers, because it depends first on what was the answer that we gave to the first question. What is the biological status that we are going to accord to the human fetus? If we are going to see it as a continuous process, or if we are going to see it as a process that has different moments according to a qualitative approach. And it depends on the concept of person that we have. And as you know, we have more than 200, 300 concepts of person, and that philosophical and bioethical concept of person, they are all different, and we cannot say that one is better than the other one, since in philosophy we do not have progress, and in bioethics what we have is different approaches to the same problem. And then we have the problem of the legal status. Should we recognize personhood to a human fetus? And the answer to this question depends on the answer that we gave to the first two questions. If we consider that a human fetus is a human person, then we have to recognize to it human personhood. If we consider that it is a future person, as the authors of the article that I referred, then we do not have to recognize to it personhood, and so on. And the problem is even more difficult, because nowadays we do not know what a human embryo is, and we do not know what is the biological, bioethical, legal status that we should give to a human embryo. And the human embryo may be inside the woman, and then we are speaking about abortion, or maybe outside the woman, and then we may be speaking about a crime against property, or a crime, a new type of crime from criminal, according to criminal law, that would be embryonicide. But what we know is that we can produce a human embryo in different ways, and from a bioethical and legal point of view, we can accord a different status to the human embryo according to the way that we have produced a human embryo. We can do it in the traditional way of producing human embryos through egg fertilization, and a sperm is inserted in an egg and we have a human embryo, but we can also use somatic cell nuclear transfer and we will have human reproductive cloning, or we can use artificially developed stem cells, and then we will not have an egg or a sperm, or we can have an egg that will be induced to develop itself into a human embryo, or we can produce an embryo using artificial gametes that are created from stem cells. And from a bioethical and biological point of view, we have a problem, because are we going to give exactly the same status to an embryo that was produced in a traditional way, or are we going to give a different status to the embryos that are produced without gametes, that are produced with the genetic material only of a woman, or with stem cells, and we do not even have a man or a woman behind the embryo? But in the end, if we place it into the uterus of a woman, we will have a child that will not differ from the children that result from a classical embryo. And so if we look the laws that we have in force all over the world, we'll find out that bioethics and the legislator is quite confused in this field. For instance, the Human Fertilization and Embryology Act says that for the purposes of its application, an embryo will be an egg that is in process of fertilization, or that was created with other any process capable of resulting in an embryo. So it's a very broad approach to what is a human embryo. Also, the main directive that we have in the legal protection of biotechnological inventions that has many times been altered in the definition of what should we understand by a human embryo, nowadays states that a human embryo is any human ovum after fertilization, any non-fertilized ovum into which the nucleus from a mature cell has been transplanted, any non-fertilized human ovum whose division and further development have been stimulated by parthogenesis constitute a human embryo. So the first thing that we know is that we do not know what a human embryo is from a biological point of view. We do not know if we are going to recognize the same protection to a human embryo before and after implantation.
Ya, jadi anu ya, hari Sabtu ya.
Excuse me.
Yes.
Please unmute. Please mute your microphone for the other participants, except only the speaker, because it is disturbing. You can proceed, Professor Helena de Melo.
Thank you, Professor Melo. So the first question that we have is, are we going to give the same protection to the human embryo before implantation and after implantation? Are we going to give the same protection to the human embryo regardless of where the embryo was produced? What is a human embryo from a biological point of view? What is a human fetus is from a biological point of view? And if we do not answer to these questions, it's not possible to take a serious decision when we are speaking about abortion. So first, we saw that we do not know what a human embryo and a human fetus is from a biological point of view. It depends on the approach that we have. And this approach is conditioned by the criteria that determine.
Saya kira saya terima kasih sudah sedemikian rupa.
Excuse me. For the other participants, please mute your microphone because it is disturbing the speaker. Okay, Professor de Melo, please proceed.
Thank you very much. So here we have to determine what is a human person, and we have many criteria as well. We can have the criteria of the genetic constitution, and we shall consider that we have a human person when we have an entity, an organism that has a genetic constitution that belongs to the human species. And then we shall give exactly the same protection to the fetus and to the embryo and to the person who already has been born, because they belong to, from a genetic point of view, to the human species. But we can also consider other criteria, like the criteria of rationality, being able, like Descartes said, to think and to decide in an autonomous way, or the criteria of communication, being able to have a language, oral or written language, and to communicate with others, or the ability to feel pain and pleasure, as Peter Singer has proposed. But what is really interesting is if we use these different criteria, we will have different conclusions when we apply it to different animal or human entities. Because if we consider the criteria of reasoning, then probably only the person who is lying in the hospital bed will be considered as a person. But if we consider the ability to communicate, probably that person will be excluded from personhood. If we consider the ability to feel pain, probably we will accord a better bioethical status to this chicken than the bioethical status that we are going to accord to a human or to an embryo or fetuses. So again, it is very important to define what is the criteria of personhood that we are going to use when we are speaking about the bioethical boundaries of therapeutical abortion. And so, when we look at a fetus, do we see a human person? Do we see, as Aristotle proposed, a potential human person, an entity that at a certain moment after being born will become a person because he will be able to communicate or will be able to exercise its autonomy? A future person, and he'll only acquire personhood 2 or 3 or 4 years after being born, or only biological material, according to what an American professor, Tristan Engelhardt Jr. proposes. And this means that it will belong to the parents who have produced it, and they will have a right to decide if it lives or if it dies. So different options will lead to different solutions from a bioethical and biolegal point of view. And if we see the different conceptions that we have had in Europe during the last 20 centuries in this field, and here I bring you the definition of Boesio, that was the most important definition that we have for more than 10 centuries, we shall find out that the fetus will not be considered as a person if we apply rationality. But we'll have doubts if we move to St. Thomas Aquinas, if we consider somatic cell nuclear transfer, and define the person as something that cannot communicate to another, because from a biological point of view, it is possible to communicate the biological constitution of a person to another person nowadays. Or if we move to the personalists, namely to the French personalists, that say that a person is something that is unique and cannot be repeated twice. From a biological point of view, if we consider that a human being is a mammal, and what can be done with a mammal can be done with another mammal, nowadays we can replicate a person from the biological point of view. So we do not know what embryo or fetus is from a biological point of view. We can produce it from many, many different ways. We do not know what it is from a bioethical point of view. It depends on the theory that we are going to apply. And if we look up around the world and see the abortion laws that we have in force, we'll find out that we do not have only way of answering to this question. What we have is very different approaches in different countries and in different regions of the world to the issue of abortion. And this is recognized in our main convention, the most important legally binding convention that we have in Europe, Convention on Human Rights and Biomedicine, that was signed in Oviedo in 1997 and has been signed and ratified by almost half of the countries that are members of Council of Europe, although it has not been signed by the countries that have most important research projects in embryo research and that have very developed medically assisted and fetal medicine, namely German, Russian, and the United Kingdom. And what the convention says is we are not going to define the protection that should be accorded to the fetus or to the embryo. We are going to leave it to the national legislator. So when we recognize the right to life in Article 2 that says that everyone should have his or her right to life respected, we are not going to define who is the person, everyone, or in French, toute personne. We are going to let the national legislator and the national courts to determine who should be the organism, the human organism that is entitled to have his or her right to life respected. And we find in the World Medical Association statement on medical indication, termination of pregnancy, exactly the same solution. It tells physicians that they should respect, when speaking about termination of pregnancy, the law and regulations that you have at the national level, that they are completely different from state to state. And all that the World Medical Association tells the physicians is that they should respect the main principles that we have in bioethics, namely promoting women's health. And this means that you have to help women when they decide to terminate their pregnancy, in the sense that they cannot be left in a situation that may endanger seriously their health. The dignity, and human dignity is the basis of all bioethics and biolaw in UNESCO, in the United Nations, although we do not know what dignity is, and you will have different concepts of dignity if you understand it as a pro-life concept of human dignity, or a concept of human dignity centered in quality of life. And the solutions will be absolutely different when you speak about therapeutic abortion. And also you have to respect informed consent, because when you speak about abortion and you have not respected informed consent, you will have a crime, because since the right to health and the right to physical and mental integrity and the right to liberty of the woman will be seriously offended. Also, you'll have to respect confidentiality and privacy as human rights and as something that is respected when you're applying and when you're applying medical law in general, but that is all that is said. And the rest of the criteria are determined at the national level and by national medical associations, simply because we have different approaches to the problem of abortion all over the world. The same solution can be found in the Charter of Fundamental Rights of the European Union, that says that when we are speaking about the medical field, we have to prohibit at the national level all the eugenic practices, and this is linked with the memories of what happened in the Nazi concentration camps during World War II, namely the clinical trials. Prohibition of human reproductive cloning. Non-reproductive cloning is not prohibited at the European Union's level, but it should be decided at the national level. And again, this means that we can produce embryos through stem cell research, and this is perfectly acceptable at a national level. And so the main problems that we have are linked with eugenic abortion. And eugenic abortion is or may be used for negative eugenics, and this means to try to stop the birth of children who suffer from disability or from disease, or for something that is a new concept that was created by Professor Rui Nunes, a dear colleague of mine, that is the concept of dysgenics. And dysgenics means that we are going to deliberately create a child who suffers from disease or disability. And eugenic abortion may help us in order to achieve that purpose. And so when we see the laws that we have all over the world in eugenic abortion, we shall find out an eugenic abortion is a therapeutic abortion in the sense that it is determined by the right to physical and mental integrity, but mainly mental integrity of the woman. We shall find out that sometimes, or usually, it is only allowed when we have a very serious probability of disease or disability. But even in these circumstances, and I bring you a case where it is allowed almost everywhere. Even in these situations, we have groups of people that say that the life of these children is worth living, and they are using a criteria to determine personhood that is a criteria linked to the fact that this child belongs to the human species, she has human DNA. But we also have countries like my country where you can have a therapeutic abortion when the child suffers from diseases, and these diseases are perfectly treatable or curable after birth. And so here we have a very serious discussion of who defines what is a disease, what is a disability, what is a disorder, when is it to be considered as serious, and when is it to be considered as something that is acceptable within the concept of therapeutic abortion and eugenic abortion. And when we speak about eugenics, we have the situations in which minorities, and I bring you an example, ask to use pre-implantation diagnosis and embryo selection, or prenatal diagnosis and eugenic abortion, in order to have a child with a disability or with a disease. And this has happened in the United States, where a deaf lesbian couple decided to have a child that would be deaf as they are. And you also have it with Little People of America, when people who suffer from nanism want to have a child that suffers from nanism just as they suffer. And here you have another discussion, that is the discussion, what is a disease, what is a disability, what is a cultural minority? Because the deaf community tells us that we are not disabled, we do not suffer from a disease, we have our specific culture and our specific language, sign language, and you have to respect our reproductive options and to allow us to use to have the possibility of using abortion in order to have a child that fits in our own conceptions of what is a good life. And then you have also here a problem that is not linked with medical reasons, but with social reasons of using abortion for the selection of sex. And this is used in India, this is used in China, and we will have serious problems in 20 years when men do not have enough women to marry. And probably this will have problems as well, serious when it is considered from a geostrategical point of view, because we will have wars in order to have enough women for the countries that do not have enough women in 20, 30 years' time. But we are also doing it for medical reasons. And for instance, when we have a disease linked with the sexual chromosomes, we accept the selection of sex and we accept abortion for the prevention of the disease. But sometimes we even go further, like in hemophilia, and we accept that a woman who is the carrier of the disease but probably will not show the symptoms, will not be born because she has the probability of transmitting the disease to the next generation. And here we have again eugenics. Should we do it? Should we not do it? In Europe, we are doing it. And what the World Medical Association says is that sex selection is linked with sexual discrimination and that we should not accept it because underlying the decision of abortion for sex selection is the idea that it is still better in the 21st century in many countries to be born as a man than it is to be born as a woman. And so it should not be acceptable unless we have serious medical reasons in order to do it. And so what we have here in eugenic abortion is a discussion. Do we have a conflict of rights? Is it medical abortion in the sense that we have, on one hand, the right of the mother to mental health and to have a child that is in accordance to what she thinks that should be her responsible exercise of maternity? Or do we not have a conflict of rights and we have a child that probably will have a disability or will have a disorder and a woman that simply does not want to have it? Or do we have what the physician that created the first in vitro baby in France, Jacques Testard, says, that is we are having a new eugenic policy that is democratic in the sense that it is not imposed by the state, that is sweet in the sense that it results from decisions of many couples that decide not to have the child when you have a child, for instance, with Down syndrome. And if all the couples take the same decision at a certain moment, everyone is invited to decide in the same way. And it is something that slowly is entering our societies. And this is a serious discussion that has yet not been done in many societies, simply because we are using the techniques and not questioning from a bioethical point of view if we should do it or not. The World Medical Association says that in spite of all these discussions, the physician always has the right to objection in performing an abortion. He has the freedom of thought, the freedom of conscience, the freedom of religion, and he always is able to say, I do not want to participate in this type of medical interventions, but nevertheless, he has to help the woman and he has to prevent serious injury to her health and to send her to another colleague if she wants to perform it and national law allows her to do it in that situation. Another thing that is important here is the Universal Declaration on Human Genome and Human Rights of UNESCO that says that everyone has the right to respect to their dignity and to their rights, regardless of their genetic characteristics. And here we could ask if a child with Turner syndrome or with Down syndrome that have a genetic constitution that is different from the genetic constitution of the average population should have their right to be born respected or not. Is it having a constitution that is different from the majority of the population, something that entitles you to have your dignity and your basic human rights respected. And again, you have different conceptions and different answers according to the conception of dignity that you are using. We cannot consider abortion, therapeutic abortion, without considering what we are doing in the medically assisted or the reproductive field nowadays. And we have to see that more and more we are altering our genetic constitution, more and more we are trying to have children who are healthy, who are going to be beautiful, who are going to have a great lifespan. And we are doing it through pre-implantation diagnosis and systematic embryo selection. We are doing it through genetic enhancement. If it is possible, we are doing it through genome editing. And we all know the situation that happened in China, where the first CRISP babies were born that had their genome altered in the way that they will not be affected by the HIV virus, and their children will not be affected as well. So it has already begun, and it is more serious than it was before to answer clearly to these questions that do not have only one answer. What is a human fetus? God knows. What is personhood? Many answers possible. What is a legal person? It depends on what we consider the concept of person that we have. Is it important to have genetic inheritance that has not been artificially modified? We have considered it up to now, but things are changing, and that's changing very quickly. Is it even important to have a human genetic constitution in order to be a person according to bioethics and to the law? Here you have two main trends. One that is the conservative human dignity approach that says that we should accept what law, natural law, broadly understood as something that is given by God and by God's will, and that we have to respect, or that is given by a certain nature, a natural order that we have to respect and we should not interfere with. And we have a bioprogressive approach to human dignity linked to transhumanism and to posthumanism that say that the human species as we know it now is not enough, and we should move from Homo sapiens sapiens to something different and better from a biological point of view. The bioconservative approach tells us that biotechnology and medicine should only be used for therapy, and so we should reject all the other applications of it, namely in what concerns the possibility of eugenic abortion, in order to ensure that we'll have a better human being from a biological point of view. It is still the conception that underlies our main legal texts that we have in Europe and in the United Nations, but the bioprogressive approach to human dignity is becoming more and more reality. And again, we have two possibilities. We have transhumanism that tells us that we should use the new technologies in order to become better humans from a biological point of view, but still belonging to the human species. And we have the posthumanism approach that says that, well, we should use all technologies to become better, and even without a biological background. And we could have nanotechnology, biotechnology, informatics, and cognitive or comportamental sciences helping us to do it. And in this vision, eugenic abortion is ethical, legal, acceptable, and even desirable in order to have humans that will be healthier and better from a biological point of view. And to end with, I bring you a thought of Hannah Arendt that was written 70 years ago, but I believe that nowadays it is something that has full application. We are doing many things from a technological point of view and from a medical point of view. We are accepting them in our day-to-day life, but we are not fully understanding what we are doing, namely the consequences for the future generations. And the main concepts that we have in biology and bioethics and in law do not allow us to answer fully and to understand fully what we are doing. That will have serious consequences for the human species considered globally in our planet Earth. And thank you very much for your attention.
Thank you very much, Professor Helena Pereira de Melo, for your great presentation. We will have the discussion after all speaker will be presented their slides. Now, for the next opportunity, I would like to invite Professor Ito Puruhito. He is a cardiovascular thoracic surgeon, and he will speak on the challenges on the open heart surgery. Professor Puruhito, the floor is yours.
Thank you, Dr. Manopo, for giving me the opportunity. Thank you, the ICS, for inviting me to speak in this forum. And I would like to apologize to the other speakers before me, because what I will like to talk is a difference to the former speakers, namely talking about the cardiac surgery. I will try to share my slide.
Sure.
Just a moment. So can you see the slide?
Yes, perfect.
Thank you very much. So what I like to talk for this session is the challenges in open heart surgery. Maybe you will ask why it is so challenging, the open heart surgery. Because open heart surgery is different from the normal usual surgery, because in open heart surgery, the heart is being put to a heart-lung machine, and the surgery is performed under the so-called extracorporeal circulation using the cardiopulmonary bypass. That means that the heart is being put in still stand, and with that heart in still stand, the surgeon can do something to the heart to repair. So it is normally done after we open the chest. It is usually to a median sternotomy. The heart is connected by a special tubing to an extracorporeal circulation, and then the surgeon can repair what he has to do with the heart. And then after it's finished, the heart is then being put back in normal circulation, and cardiopulmonary bypass is cut off, and the heart is uh, uh, working normally. The second background, why it is challenging, is the operating room or the operating theater. And for open heart surgery, the operating room is a complex environment in which highly trained subspecialists interact each other. The surgeon, the anesthesiologist, the cardiologist, and try to heal the diseased heart. And that's why it is desirable that the operating room for heart surgery should be set as a full dedicated operating theater. So I'm not advising that surgery for open heart should be done in the normal operating room. It should be only done in a specialist dedicated operating room for open surgery. Uh, there is also another background why it is challenging. Uh, in my experience, there has been a limited success in establishing open surgery program in Indonesia, even in Surabaya. A famous private hospital in Surabaya was in the past, as I was still in a very active ages, uh, doing the open surgery routinely, but now they are closed. It's not continued or discontinued. On the other side, there are some new private hospitals who can perform now open surgery. So although the high prevalence of heart disease in Indonesia is still high, unfortunately, to establish an open heart surgery is not so easy in Indonesia. And also, we knew that a lot of Indonesian people who has a heart disease still try to look for treatment uh, and travel abroad for open heart surgery. So, for these reasons, I would like to share what are the challenges and constraints to develop an open heart surgery program in Indonesia, and it should be now identified and overcome. This is the view of a surgery, open heart surgery, in Dr. Sutomo Hospital, the so-called Dr. Sutomo Cardiac Service Center, Pusat Pelayanan Jantung Terpadu. And you can see here that the operating room is full with everything. These are the surgeons doing surgery and the patient, anesthesiologist, and important, there is a heart lung machine in it. And this machine will take over the function of the heart and the lung during we, the cardiac surgeons, doing something to the heart. And the most important part, machine is this kind, what is it called, oxygenator. There is the heart and lung substitute to the patient. So this how it looks like the operating room and how the atmosphere if we are doing the open heart surgery. Once again, I have defined the open heart surgery as a repair of the heart during which the blood circulation is maintained mechanically, which is required the so-called cardiopulmonary bypass. And now, what can we cardiac surgeon do with the heart during the open heart? Well, we could do everything, of course. Number one, we can repair or replace heart valve, which is diseased, maybe by rheumatic heart disease, or we can repair the damaged part of the heart. For example, after the cardiac infarction, or also we can repair the disease heart which is caused by the congenital heart defect. Sometimes also to implant medical devices to support the heart, so-called left ventricle assist device, or even what we call mechanical heart. And of course, we can replace the whole heart by doing the cardiac transplantation from a cadaveric donor. So there are a lot of things that we can do with the heart if we are doing the open heart surgery. And how it's done is a little bit complicated, of course. The patient should be admitted to the hospital at least 1 or 2 days prior to surgery and prepared with informed consent and other necessary examinations. And then during the surgery, the patient is given general anesthesia, and this should be done by a specialist anesthesiologist, or we call them the so-called cardiac anesthesia or cardiac anesthetist. And surgeon will do the median sternotomy. Sometimes we can also minimize the approach by the so-called minimal invasive cardiac surgery, which is also done in Surabaya as well and established a lot part of the world. And then the patient is connected to the heart-lung machine. The heart and lung function is taken over, and then the heart is in still stand, and the surgery upon the heart is being performed. And after the endeavor, heart and lung is put back, and connection to the heart-lung machine is cut off, and then the chest is closure, and patient is back in normal functioning his or her own heart and lung. This is how it looks like during the surgery. Once again, correction of surgeons, the main cardiac surgeon, the assistant, the heart lung machines, the patient here under the anesthesia. And I will show you some few of some cardiac surgery that we perform daily. These pictures are courtesy from PPCP or the Comprehensive Cardiac Services of the Sutomo General Hospital. Number one, for example, is very important, very popular now is the so-called arterial coronary bypass. It is a coronary heart disease. These are a patient in which you can see from the skin there are a lot of stenosis of the coronary surgery or coronary vessels, and of course the heart is decompensated, and then we do the so-called CABG, Cabot's coronary artery bypass graft. Okay, next, where we, for example, a child with the tetra of Fallot, which is very popular. So we perform preoperatively the so-called what do you call echocardiograms, also functional echo, so we can see really what is happening with the congenital defect. For this example of the radiographic examination, we can see that the pulmonary vessels and also the outflow tract is a little bit small, and we need to repair that. So this is the scheme of the phallotetralogy, the so-called PST, ventricular defect of the hypertrophy of the right ventricle, the stenotic pulmonary valve, and also pulmonary vessels, and the off-riding of the aorta. So we repair it by closing the PSD, and then enlargement of the infundibulate tract, the so-called right outflow tract. And after the resection of this stenotic outflow tract, we just make a so-called a patching of the outflow tract, so it can be done easily. So this is an example of the surgery of the congenital heart disease. We can also try to repair a mitral valve, for example, in this patient. We will see that the mitral valve is regurgitating or insufficient, namely it doesn't close tightly. So we make a so-called mitral valve repair by doing this and put a ring on that. So the mitral valve is back in normal function. Those are examples of seen in open heart surgery that we do now in daily routine. Of course, we are not talking about the risk for open heart surgery. Why it is risky or more risk compared to the normal surgery? Using the extracorporeal circulation with administration of heparin or heparin administration or heparinization is prone to post-operative infection. Secondly, also there is a risk of chest wound infection, and is more common in a patient with obesity or diabetes or another comorbid. Patient can also develop heart attack or stroke or dysrhythmia, or even sometimes lung and kidney failure. They just need hemodialysis or renal replacement therapy. Of course, patient is suffering from chest pain and sometimes fever. Some reports so-called memory loss or fuzziness, although this issue is now being modernized and almost zero of this complication. But blood dysfunction can also happen with clotting or even blood loss by bleeding. So there are a lot of risks for open surgery. And of course, during the heart-lung machine, whereby the lung is taken over by the ventilators, it can also develop post-operatively breathing difficulties and pneumonia. So, what are the challenges in performing open heart surgery? Number one, the most important challenge is how to build a teamwork that can work under stressful circumstances. Yes, almost all the personnel during the heart operation or open heart operation are under stressful circumstances. Secondly, it should be completed the surgery if we have good surgical instruments. Also, there are also so-called disposable devices or the so-called consumables. So we have to have a good collection of various tubing sizes and lengths, and so on. Number three, of course, we need to be supported by diagnostic devices like echocardiography or cardiac monitoring devices. Also, the presence of the so-called heart-lung machine, which is also very costly. And of course, the perfusionist is the person who run the heart-lung machine, and of course, medicine for that. Number four, of course, we need well-trained theater nurses, the scrubbers as well as the assistant. And of course, once again, operating theater with good sterile air exchange and suitable cool temperature. It should not be too hot if we are performing open heart surgery. What is cardiac team consist of? The open heart so-called cardiac surgical setup consists of one, two, or three cardiac surgeons, cardiologists, perfusionists, cardiac anesthesiologists, and so on. So at least a team of uh, 10 to 15% who are doing or making surface to open heart surgery. And then this team also then works later on, most of it in the coronary intensive care unit, or sorry, cardiac intensive care unit, is ICU special for heart disease or heart post-operative heart surgery, and it should be mostly services by three theater nurses or three intensive care nurses with the 8 hours of shift. So we need that shift because there's a lot of work being done after the heart surgery. This is another scene during the operation. You can see the main surgeon, the anesthesiologist, assistant surgeon, the perfusionist, the assistant, the nurses. So it looks that it's only 8%, but actually uh, outside of this 8%, there are some working or people who move to give the instruments or the consumables to the need of the surgery. So normally between 15%. How about the post-op care? It's also some challenges because the post-op care is also important part of the open surgery. After the surgery, the patient are being taken to the ICU and need cardiac or respiratory support by the ventilator. And patient will be moved to the side room. And in this ICU, normally the patient will stay between 1 or roughly 3 to 5 days after the, the surgery, and then being moved to ward. And patient could be discharged home after maybe 1 week after the entrance to the hospital. And then the patient is asked to come back to the ambulatory services about 2 weeks thereafter for a follow-up and check the wound and so on. How about the patient safety? Yes, because there are guidance from the American Heart Association, which is a commission to summarize the evidence regarding the risk of the patient safety. Normally, we have kind of preoperative scores. The score can be calculated uh, by the condition of the patient and calculating the risk for that. And there is a comprehensive view of all potential risks which already tested. So we can predict before the operation how many percent could be successful or how many percent are the risk for something to happen after the surgery. And of course, we also calculate the environment, cultural factors, psychological, teamwork, and so on, and how the team communicate within the operating room. There's also some organizational culture, namely safety, climate, and quality improvement of the cardiac operating room. Those are subject of patient safety in operative surgery, which has been pictured in this scheme done by Joe's Watt and the circulation. So you can see here from the high hazard procedure to the possible death, which is influenced by a lot of subjects in this picture. You can see the healthcare organization, the hospital management, the cardiac care department, decision makers, and other problems. So these are factors affecting the patient safety during the open heart surgery. So to summarize the challenges in operative surgery, I would like to share with you this subject. Number one, we need a follow of cases, and this makes the so-called learning curve. Because I was pioneering the cardiac surgery back to 1973, I can still remember that the volume was very low. Sometimes in that time, I did only once a week, or no, even once a month. So there was years that I did only less than 10 open heart surgery a year. Yeah. So now we can do 10 open heart surgery a week, 2 per day, and with 5 days a week, we can do roughly 6 to 10 open heart surgery per week. So the volume of the case will give us the learning curve. So now the young surgeons doing faster learning curve than compared to as I was starting the open surgery. Of course, the working environment is important. As I told you before, how to set up the operating room. For this reason, we can now train the young surgeon and make some better exposure, better experience in various technique and cardiac surgery. Of course, we need also the library support and facilities during performing the heart surgery. Radiology equipment, which is now also combined in the so-called hybrid theater. So we have also in Sutam Hospital, the so-called hybrid theater. We can do radiology, we can do interventional surgery. Blood bank facilities should be prepared, of course, to provide enough blood and blood parts during the surgery. The cardiac catheterization unit is now also embedded in this theater through the so-called hybrid operating room. Of course, most important, the financial support. Which is, as you can see, well, it's still expensive. Yeah. Fortunately, the government insurance, the BPJS, can cover now the cost of the open heart surgery, although still in limited circumstances. But last but not least, this is what we are facing in the challenges. If we are dealing from the patient's condition point of view, and namely, if the patient is dealing with this kind of situation. Number one, extreme body weight, too low, very low, For example, premature or undernutrition, or even too big. There's a obese or overweight patients. Yeah? Sometimes to more than 100 kilos of body weight. This also special challenges looking from the patient point of view. The age of the patient, too young, neonates, infants sometimes, or premature babies, or too old. Yes, we did a lot, some, not yet too many, but more than 80 years of patient, well, one or two with more than 90 years of age. And maybe we will do surgery more than 100, who knows? Yeah. Those are the special challenges. Of course, we are dealing with high-risk patients, patients with bad hemodynamics or severely decompensated heart with comorbids and another high-risk patient. Also, there's a challenge if we are dealing with complex congenital heart anomalies, also heart anomalies in congenital twins. You know that Surabaya is now popular for its successful conjoined twin separation, but some of these babies are having also the heart disease, and there's a special challenges if we are doing the heart surgery in these conjoined twins. And last but not least, of course, if there is an emergency, for example, heart attack or trauma uh, or septal rupture, which can happen anytime. So these are the challenges, extra challenges I share you, and I would like to thank you for your attention. Thank you very much.
Thank you very much, Professor Puruhito, for your nice presentation on open heart surgery. Now we come to the discussion session, but before that, I would like to invite Professor Andi Arsadul Islam to address the summary notes. Professor Andi, the floor is yours. Professor Andi, are you on the line? Okay, I will skip, and then we come to the discussion session. The first part of the discussion session will be the inter-speakers discussion. So each speakers could ask question each other. And for the first opportunity, I would like to invite Professor Emilia. Have you any question to ask to the other speakers? The time is yours.
Thank you very much, Pak Peter, for the opportunity. I think all the presentation is very interesting. The one that is presented by Professor Helena is looking at the different side of the issues. So when clinicians as the point of view is sometimes is different. So having the discussion like this is making we have a rich views about the case. But sometimes also the clinicians also have like a difficult time to decide. Yeah, for the abortion. You mentioned about the a person or a fetus with congenital anomaly, and it can be it can alive. So in our situation, the regulation is like, if as long as the fetus not possible to be alive, then that is the indications for the medical abortion. But if it is possible to be alive, then that is the opportunity for the fetus to grow and to have life, of course. So I think this should be decided together, not only for by the physician, but also by the mother And also, I think here to by the team that is manage the case itself. Yeah. So sometimes it is like difficult to decide for the clinicians. So it is not the real question, Pak Peter, but it is like a situation that is difficult to decide for the clinicians, I think. Yeah.
Thank you, Professor Ova. Professor Helena, would you react for this statement?
Yes, I will. Thank you very much, Professor Emilia. What you're saying is really serious, because being a physician in the 21st century must be very, very difficult, in the sense that technology allows you to do more and more. The population expects you to do more and more. The population is much more informed than it used to be before, so it controls much more the acts of the physicians, if the physicians do or do not do. And the ethical dilemmas are the classical ones. And you have new ethical dilemmas as well. For instance, when you speak about viability, the frontiers of viability are changing month by year, because you are able to keep the child alive out of the mother's womb, earlier and earlier. So I think that now you are in 6 months, a little bit less than 6 months. And when the child has a disability or has a disease, your decision is even more difficult, because you can decide to allow it to be born or not. And so here it is very important, the intervention of ethics committees at the hospital level, since the decisions many times are not medical decisions. The decisions are decisions about what type of community we want to be. If we want to be a community that has space for people who are different from a biological point of view, for people who are going to suffer and to show the symptoms of very serious diseases or disabilities, if we are going to give them support, health support, social security support, or if we are a community that only has space for the ones who are more healthy, for the ones who are going to be more beautiful, who are going to need less the services from Dr. Ito, and that give us a promise of a good biological constitution. And that is not a medical decision. That is a decision that should be taken by physicians, by people who work in the religious field, by people who have different approaches in the political field, by common citizens. All these people in each society, and even at a global level, should be called to determine when and how should the baby live.
Okay, thank you, Professor Helena. And now the opportunity for Professor Helena to ask questions to the other speakers.
Thank you, Professor Peter. I would like to ask Professor Ito what he thinks about the possibility of creating artificially human heart organoids.
Yeah.
Well, that's a good question, but later I would also ask you some other question. Okay, now we are developing in a stem cell because I'm also now interested in stem cell medicine. It is possible by tissue engineering and stem cell engineering that we are creating a new heart by regenerative medicine. So it will come a time that the medicine or the medical community will produce a total heart, a total biological heart through regenerative medicine. And of course, we as surgeons are very happy if that can happen. Now, what we are doing is still part of the heart. Some surgeon or some industry can develop the heart valve by regenerative medicine. So I really welcome if we can do that. On the other part of the bioethicist, as you told us before, why an unencephalic baby cannot be born or can be born because some of the heart transplantation among the neonates and infants is having a donation from the heart of an uncephalic baby. So there's another horizons of the use of this human, although they are not well a complete human, but part of their body can be donated for the sake of the other people's disease. What do you think about that? So these are the questions that what I like to ask also to Professor Emilia. Why should a baby be aborted if it can be let it live until adult? We are talking about the so-called unintended or unwanted pregnancy, or a real mid pregnancy to born a baby, something like that. What do you think? This is a very complex questions, but answering the question of Helena, yes, we are welcoming the new step of regenerative medicine to produce a totally biological heart from regenerative medicine.
Brief Professor Helena first to react Professor Puruhito question. Professor Helena, you have the opportunity first to answer the question of Professor Puruhito.
Thank you very much, Professor Menopo. Your question may have two answers. One answer is that obliging a woman who is pregnant with an I cannot say the word easily, with a baby that will be born without a brain or only with a part of a brain, may be thought as something very terrible for her. The suffering may be terrible, and so having in mind the mother, you may accept eugenic abortion so that she will be able to move on with her life and not being pregnant for 9 months in order to have a baby that probably will die in 2-3 weeks, or that will be severely damaged, although the word is not a good word, will be severely handicapped. Another way of looking at it is that the mother may show some solidarity to the community and may accept to endure the pregnancy for 9 months in order to have a baby, and the baby will be an organ, and tissue donor to someone who needs a heart, who needs a kidney, who needs an organ. And that we can say it on the basis of what we have in our transplantation laws, that when you have a system of opting out that we have in a great part of Europe, it means that we believe that everyone wants to show solidarity to people that we do not know, and within this idea we are accepting and willing to give our organs when they may be useful for another member of the community. So that is another possible answer to the situation, and it depends here not so much on the bioethical approach or the legal approach, but on the approach to that specific matter, what she wants and how she feels about the terrible situation in which she is, that is giving birth to a child that will suffer for a very, very serious hand. Another thing that you are raising that is very important is the issue of immortality. And I was listening to you and thinking that you are going to probably make surgeries in people who are 90 years old, 100 years old. And if you accept human reproductive cloning in order to produce people who are going to be organ donators, and we can produce a clone only to harvest organs and tissues from the clone, and we will not reject them because we are working with someone who has the same nuclear DNA that we have, then we will be able to achieve immortality through your work. We need a new heart, no problem. You will perform an organ transplant using the heart of our clone that has been kept alive in order to provide us a heart when required. And that is something that is open from a medical point of view, not only with children without brain, but also with the possibility of creating a person only to for the purposes of organ and tissue donation. And I could ask Professor Emilia and Professor Ito, what do they think about this new possibility, not of organoids, but of a complete full body? Our clone.
Professor Emilia, would you please react to the question from Professor Puruhito and Professor Helena? Time is yours.
This is interesting discussion. So for Professor Puruhito, I think the unintended or unwanted pregnancy is more a social than the medical problem. And actually, in terms of the medical indication, we only thinking about the maternal or the fetal condition that that needs some further intervention. So for the social indication, unintended or unwanted, this is not like each country have different like regulations. Like in our country is illegal unless it is rape, or it is an incest, and that is also still debatable, and for that reason that we really campaigning the contraceptions. So we for in our specialty, we think that contraceptions is one of the way out to prevent the unintended or unwanted pregnancy, which also will contribute to the reductions of the abortions itself. And Professor Helena posing a very, I think that is a future medicine, that is, you are right, that it is more complicated than we think. That can we we create or we culture a tissue and then we grow it up to a certain donor or organ and to put it as a donor in, for example, in Professor Puruhito surgery, for example. That is, I don't have the answer for that, and I don't know. That is one of the future medicine that need to be discussed not only by the clinician, bioethician, and also the in a religion perhaps, and the social context. That is, I think, different from one place to the other place. Thank you, Prof. Peter.
Yeah, thank you, Prof. Emilia.
Professor,
Professor,
can I ask Prof. Emilia?
Sure, Prof. Puruhito, you can do it.
Yeah, Professor Emilia, I would interested in your second case you presented before, because my question is why you aborted such kind of baby? Because the baby only, in my opinion, have an paratus cases or rabies cases or unanswered health, why it is being aborted? And the woman was in the 27th of pregnancy. Is it not too old to make an abortion on that patient? And this your second case, I think so.
The anomaly is acrania without cranium. Acrania, and then cleft lip and palate and gastroschisis. So multi-organ anomalies, congenital anomalies.
And
So
why this 27 weeks to wait?
27? Because they live in the rural areas and they don't have the ultrasonography examination in the early trimester. So it is found late in the 27th week of gestation. And I think, but this kind of case is I think, perhaps in the city or in the urban area is we cannot find this case anymore. But in the rural area, still we have this where ultrasonography is not usually performed.
Thank you. Yeah, thank you, Professor Puruhito and Professor Emilia. Professor Helena, do you have any comment for the last opportunity for you?
Thank you very much. I would like once again say that I'm very honored for the invitation and that it was a pleasure to be here.
Yeah, I have a question for you, Professor Helena. Based on your experience, to what extent could you make proper ethical deliberation for the case of medical abortion just by social indication, like unwanted pregnancy or unmarried couple? Is it you can make very early decision that it is not it is unethical, or you should elaborate about the background of this situation? Thank you.
Thank you, Professor Manopo. That's a difficult issue in the sense that from a legal point of view, what we usually do, and I do within the United Nations, is that we use the definition of health of the World Health Organization that was adopted in 1948 in its status, that says, as you know, that being healthy is not only suffering from a disease or an infirmity, but a complete state of complete welfare from a mental, physical, and social point of view. With this broad concept of health, then you have a right to health protection that tells you that when something affects you in your mental health, in your happiness, you should be allowed to be considered as being offended or violated in your right to mental integrity. So when a woman is pregnant and she feels and wanted, and that gives her a big disgust, and that makes her very much ill. And our laws in Europe accept that she may ask an abortion on demand. This is from the legal point of view. From the legal point of view, you can have an abortion on demand in Portugal, in Spain, in France, in England, I think that in the United Kingdom, because it is thought that not doing it, you are offending the mental integrity of the woman. That is the legal approach that you have nowadays in Europe, in many countries, not probably in Italy, not in Poland, because of the influence of the Catholic Church, but in many countries you do have it. From an ethical point of view, and that is a different way of approaching it, I could tell you that I have many doubts, because you are only considering the rights of the woman. You are speaking about the fetus as someone who has no rights because the fetus has no personhood, since he or the fetus will only have personhood after birth. According to the civil laws of many of the European countries, you only have personhood after complete birth and sometimes viability as well. And so this means that you are considering that the fetus has no rights, that the woman has a right to health protection and to mental integrity. And the only way of respecting the right to health protection of the woman and to her mental integrity is by sacrificing completely the life of the fetus. I have many doubts in the sense that probably you could have another way out, and that could be adoption, that could be giving better conditions to the woman, because I believe that no woman likes to perform an abortion. Many times she has no alternatives from a social economic point of view. So the solution that we have from a legal point of view is the solution that democratic countries in Europe find is the most adequate to our societies. From a personal point of view, I have many doubts. I think that if you consider the effects of performing an abortion in the future mental health and physical health of the woman, if you consider that the fetus has no health problem at all and could be a healthy person, if you consider that we have populations that are growing old in a very fast way, and it would be good to have more children being born. If we consider that our national health systems could provide better health care to women, and that women should have a right to have their social security rights more protected, probably we could have a more fair solution. since from a bioethical point of view, it's not clear at all that pregnancy should end only because the mother wants and has expressed her desire not to have a baby at a certain moment in her life.
Yeah, thank you, Professor Helena, for your explanation. I would like to give an opportunity for Professor Rui Nunes from University of Porto, if he is attending this webinar. Professor Rui Nunes, time is yours. Okay, I will skip maybe next time. I will open this discussion, maybe one question from the floor. Any question from the floor? While waiting this question, I would like to ask a question to Professor Puruhito. Based on your experience, how could, or to what extent, how could you avoid the second look operation or the reopen of an open heart surgery by maybe by bleeding or by leakage of the wound? Thank you.
Well, thank you for the questions, Dr. Manopo. Reopen after surgery is also something that is also used to be in another surgery. Opening the wound from the abdomen after laparotomy is also things that sometimes should be done by the surgeon. The same happens also in open heart surgery. To avoid that, of course, it is our wish that all surgeons should do the surgery properly, should suture tightly, avoid from bleeding. Even though some bleeding is caused by the medical bleeding, and we should reopen, and that makes us sometimes disappointment because there is no surgical bleeding at all. But in general, to avoid that is the need of the good monitoring system after the surgery. So number one, to do surgery properly. Number two, make a good observation hemodynamic in the first 6 hours of after the surgery, because 6 hours is, in my opinion, is the most risk time after the operation is done. If something happens after those time, 1, 2, or 3 days after the surgery, then sometimes it depends on the disease. Mostly those surgery or reopen surgery happen in the complex congenital heart disease, because in some cases we should redo again what we have done during the surgery, especially for those defects concerning with the complex congenital. In adult heart surgery, this kind of happenings is rarely happens. Those are my answer, Dr. Panompo.
Yeah.
I hope
Is
you
it?
satisfied.
I will elaborate a little bit more. Is it necessary to wait about 20 minutes or 30 minutes after finishing the surgery before closing the wound, just to watch the new bleeding points or the leakage? Is it necessary, or it is not necessary?
In general, it's not necessary because after heparization, we give the protamine to stop the bloody coagulation. So if there is something with this leakage from the surgical point of view, we can see directly. We can see directly that the suture is not good, or the bypass is having trouble by clotting, or not proper what placement of the valve. So we can now use the technology by doing the echocardiography after the repair, mostly the repair of surgery, mostly the valve surgery, to see if things is already done properly or not. So the need to wait well, of course, we can wait, but it will prolong this the surgical time. So we just wait for the blood to clot properly again, and there is no leakage. And after things is good enough, and we are sure there is a proper, there's no need to wait, and we can close the chest. That's
Thank,
the usual routine doing what we do in the open surgery.
thank you very much, Professor Puruhito. And the last question is for Professor Emilia. For decision of the medical abortion, is it by individual decision by the OBGyn specialist or a team or collective decision to guarantee the independent and ethical decision? Thank you.
Yeah, thank you very much for the questions. Yeah, as far as I know, there is a committee in the hospital that is taking care of this kind of case, that is consist of not only OBGyn, but also doctor, lay people as well, and also the perinatologists. And in this team, they usually decide properly, considering not only the health of the fetus, but also the health of the mother. And we also have that the decision, the person who do the the procedures is usually uh, the one that is not deciding. So this is also to maintain the neutrality, the objectivity of the decision itself, and it should be balanced between the consideration for the mother and also the consideration for the fetus itself. Yeah. So it is decided in a team.
Do you mean it is by the hospital ethics committee?
Yes. Yes.
Yeah, thank you very much. Maybe one question from the floor. Is there any question from the floor? Okay, if it is not, so I would like to invite Mr. Max Downham to address the closing speech. Mr. Max Downham, the floor is yours. Mr. Max Downham, please unmute your microphone.
Thank you. Sorry about that. Dr. Manopo, thank you. I'm a layperson, in case no one knows it. Some of you do, I believe. I'm truly humbled by the three presentations, having been in over 100 countries of the world, both in my business career as well as in the college. The needs are just horrendous. In reference to Dr. Emilia, the maternal health challenges are horrendous. Having spent a weekend with a surgical team in a remote area of Nigeria, it's just it's beyond words. So the needs are tremendous. I also, in reference to Professor Puruhito, the technology possibilities are evolving so rapidly that it is difficult, I think, to comprehend what's possible 2 years, 5 years from now, not to mention now. And certainly the International College of Surgeons is in official relations as a non-state actor with the World Health Organization, a division of the United Nations, and certainly the topics addressed by Professor Pereira de Melo are complex, and you get into national policies, you get into global policies or global goals, and so it is a very, very complex situation. And I think the discussion, Dr. Manopo, that you have chaired has been very successful in giving insights to those complexities. So I thank you very much. I thank the speakers for the leadership of the Indonesian section, for you, Dr. Manopo. It's very, very well done, and thank you for giving me the honor to be participative in this session. Thank you.
Thank you very much, Mr. Max Downham, for your speech. And on behalf of the International College of Surgeons Indonesia section, I would like to express my gratitude for all participants, particularly to our speakers, Professor Emilia, Professor Helena Pereira de Melo, Professor Ito Puruhito for the awesome participation and dedication, and also to the office bearers from the global ICS, Mr. Max Downham, and for the Indonesian section, Professor Hendy Hendarto, and also for the IT team from Indonesia section, Mr. Bimo and Miss Devi. Thank you very much again. We will meet next month in the different topics. And I would like to wish you to keep your health and also staying safe and well. Thank you very much. Goodbye, everyone.
Thank you. Thank you.
Thank
Thank
you.
you very much.
Thank you, Peter. Thank
Yeah,
you.
thank you. Yeah.
Thank you very much.
Thank you very much. Thank you very much.